So let me introduce our final two presenters. The first is originally from Oregon and then completed her training in internal medicine at George Washington University in Washington, D.C. in 2012. She returned to Bend to begin a career in primary care and has worked in community health for the last 8 years before really transitioning to her current role in addiction medicine. She is passionate about working with the underserved and finds her job extremely rewarding. And it sounds like she says she spends most of her time off trying to keep her 2 preschoolers alive with the help of her husband, which these days, that is, I can tell you, I agree, a huge accomplishment. The other person is a doctor, has a doctorate in behavioral health. She's a graduate of the Pennsylvania State University with a degree in biotechnology. She obtained her physician assistant degree and certification at Duke University in Durham, North Carolina. She was an NHSC scholar and worked at 3 different community health centers, including Mosaic Medical Internal Medicine in Bend for 7 years. She's board certified with the National Commission on the Certification of Physicians Assistants, and she completed a specialty certification in psychiatry in 2018. She has served in the U.S. Army for 31 years, including 3 deployments in Bosnia, Afghanistan, and Iraq, and has spent the past 12 years with the Oregon National Guard as a physician assistant. Wow, thank you. So it is a great privilege to first be in compliance. I'll tell you that we need to show, yes, for both of these people, there is nothing to disclose other than the amazing accolades I have just shared about each of them. So would you please welcome Dr. Emily Harvey and Billie Cartwright, who I just have to say, Billie does have a PhD, but asked that I refer to her as Billie, which I'm happy to do. So Dr. Cartwright, hi, welcome. Thank you for being here. I'm going to turn this over to you, but I'm not far away. If I can be of any assistance, let me know. And the folks are here. Cindy says no self-care tonight, laundry night. My only disagreement is that laundry night is a lot of self-care because I feel a lot better after all the laundry is done. So thank you both for being here and welcome.
Thank you so much. Thank you all for having us. At the risk of repeating some of what you just offered, I'm Emily Harvey. I'm an internist living and working here in Central Oregon, and I'm accompanied by Billie Cartwright, who, as you heard, is a very experienced and skilled and talented physician assistant. And we come to you from Best Care Treatment Services. So Best Care, just for some background, is an organization here in Central Oregon that provides behavioral health services to patients throughout the area. So mental health counseling, psychiatric prescribing, substance use treatment in the form of counseling, outpatient treatment, inpatient residential services. We have a detox, and we have an outpatient medication-supported recovery, one in Bend and one in Redmond. So that's our current work environment. I will also point out that Billie and I go way back. We work together side by side at the internal medicine clinic here at Mosaic in Bend. So we're not that far removed from the primary care environment, and we can relate to some of the struggles you might be experiencing there because we were there not that long ago. We've been asked to talk about harm reduction today. So our approach today is going to be to start with a definition of harm reduction, talking about several specific examples of harm reduction, and more specifically, what those examples look like here in the Central Oregon area, and then a little bit of conversation about how to start that dialogue with patients when you're trying to engage with someone on the level of harm reduction. And then we thought we would circle back and spend some more time talking more specifically about buprenorphine, which is the area of harm reduction that we work in most closely. I want to point out that Billie really started our medication-supported recovery, or our buprenorphine Suboxone clinic, really single-handedly, and has built a really thriving practice. She started literally by herself with no assistance, no medical assistant, and now we have multiple providers, and we're seeing patients in multiple areas with eyes toward expansion. So she's got a lot of really wonderful experience, and we've identified some interesting cases. In preparing for this talk, we really agreed that, we remember doing the data waiver training, and it just seemed really straightforward. These cases that they presented were all kind of slam dunk. What could go wrong? Easy peasy. This isn't that hard. But I think the reality that we've found, and I'm sure that you found as well, is that patients are actually very complicated. They bring all kinds of other risk factors and issues to the table. And so Billie has come up with some really good cases that I think you might see yourself in, or that might feel a little bit familiar to you in your practice. And we also wanted to touch on some of the issues and barriers that we're facing regularly as providers, and that our patients are as well. So we'll circle back to that. So with that, I think we can. I don't know if our presentation has started, our slide deck. There we go. Okay. So we can go ahead and move forward to the next slide. We have no disclosures, as you've already heard. We lead quiet lives. Next slide. So we thought we'd start with a definition. Harm reduction is really a set of strategies and ideas aimed at reducing negative consequences associated with drug use. It's also really a movement for social justice that is built on a belief in and respect for the rights of people who use substances. Harm reduction is a preventative service. It certainly falls along the spectrum that you see below. So on the left, as you're aware, primary prevention involves trying to prevent a patient from contracting or developing an illness to begin with, whereas tertiary prevention, on the other end of the spectrum, relates more to reducing harms and reducing progression of disease in someone who already has an illness, and that's really where harm reduction falls more heavily. So next slide. This, I think, is not the accurate slide deck. Okay, we'll just go with it. So I'm going to start with the 6 sort of key principles that drive harm reduction. So the first is health and dignity. So harm reduction asks that we really see people as people first. It requires that we recognize that everyone is capable of change, believe it or not. And it asks that we provide care that is really free of judgment. Harm reduction is participant-centered, so it needs to be low threshold, accessible, practical, user-friendly. The conversation with harm reduction is really led by the participant, who is determining what the problem is, what the priorities are, and what the steps that need to be taken are. The provider in this case is really just a partner, a facilitator, and an advocate for patient care. And the last piece of this that I've highlighted is really the crux of harm reduction, which is that it really requires that we meet patients where they are, sometimes literally. And to meet a patient where they are requires that we really ask where they are. The third principle of harm reduction would be participant involvement. So this may not affect so much or impact the work that you're doing, but successful harm reduction programs are really built by and informed by the patients that they serve. So it really involves them in that process. The next slide. It also relies on self-rule, participant self-rule. So we acknowledge the autonomy of the patient, and we acknowledge their prior experiences. We understand that people will change when they're ready to change and when their circumstances allow. Harm reduction just asks that we are developing relationships with our patients that are based on transparency, so that patients understand who we are, what services we offer, and what services we can connect them with, so that if at some point they're interested in engaging in care, they know where to come and they feel safe doing so. Next slide. The fifth principle behind harm reduction would be the recognition that inequality and justice really drive a lot of behavioral issues in our society, and they also affect our patients' abilities to move forward and to break out of those behavioral habits, so to speak. So here I would remind you of the ACEs study and remind you that the patient sitting before you comes from a place of prior trauma and other issues. If you were to hand them that ACEs survey, they would likely check positive on multiple areas. And so remembering that the patient in front of you is a product of all of their past experiences and their current circumstances, and all of those factors really affect their success and the barriers in front of them. Next slide. Oh, there's the ACEs study. So in your mind, remember, I think it can be really hard. You may not particularly enjoy the patient in front of you. It may be challenging to work with, or have, they can certainly be very challenging, but it always helps me to remember that the person in front of me was once an infant. Whether that infant was wanted or cared for appropriately is another story, but that we all started from that place of innocence, and that they've likely experienced all kinds of trauma that have led them to where they are. It gives me the ability to extend more grace to my patients. Next slide. The sixth principle is that harm reduction is very practical and realistic. So it recognizes that drug use is a fact of life. It's not going anywhere. It understands that there's a very complex spectrum of substance use, and that some use is very clearly safer than others. It offers practical tools and education to address very real harms and dangers. It accepts situations as they are and deals accordingly. And here, this last one is also very important. It doesn't identify or determine abstinence as success. So success may take many forms, but it's not necessarily abstinence, which may be what you want for your patients, but it may not be the ultimate outcome that you're going to see. And that's not necessarily failure. Next slide. So just a quick moment to remind you that there is certainly a spectrum, a continuum of substance use, with abstinence on one end and very chaotic, persistent, severe use or disordered use on the other end. Your patient may be anywhere along the spectrum, and they may move. It's a very dynamic spectrum, so they may move along that spectrum by leaps and bounds, and they can do so very quickly. It's not a linear process necessarily. Your patient may have more than one substance use issue, and they may be in the green, yellow in terms of alcohol, and down towards the red or hot pink with their opiate use disorder. I think it's also really important to recognize that your patient may put themselves somewhere on this spectrum entirely different than you would. And so that's a big piece of this, is getting a sense of the patient's perception of their risk and their use. Next slide. Important also to take a moment to ask ourselves, why do people use substances and why can't they stop? People actually have fairly reasonable reasons to use substances. This may not be something that you would condone or recommend, but a patient may be using a stimulant to stay awake, to avoid an assault or robbery in a homeless camp or in another unsafe environment. They may use a stimulant to keep up at a demanding job. Certainly, we've all seen patients use alcohol and benzodiazepines to manage or self-treat anxiety and other mental health issues. They may be using heroin or other opioids to manage chronic pain. Coffee to wake up in the morning, wine in the evening, as we all, some of us may be doing tonight. And then physical dependence is a clear driver for substance use, for ongoing substance use. So I think it's important to remember that there are reasons that people use substances, and so asking them to stop may not be realistic. Patients may not, maybe your patient doesn't have good health insurance and can't get in to see a provider to address the source of their pain. Maybe there isn't much accessibility for psychiatric prescribing services, so maybe they're unable to meet with someone who can help them manage that. Maybe they're undocumented. Maybe they live in a really remote area. We have got patients who travel from John Day and elsewhere to come to our clinic for medication-supported recovery. So there are all kinds of barriers and other factors to remind yourself that it's not as straightforward as just stopping. Next slide. A graphic here to kind of remind you all of our current understanding of substance use disorder or the process of addiction. So I think this is an increasingly accepted and understood model for the process. So initially on the left, in the blue section, you'll see that early use is driven more by the reward process, so that kind of stereotypical euphoria or getting high, dopamine release. But you can see that over time, that reward really diminishes, and the primary driver for substance use really becomes negative reinforcement. So people are using to maybe to stave off physical symptoms of withdrawal or to treat anhedonia. People kind of transition to a state where they're ultimately in time using to feel normal, not to feel good or amazing, but just to kind of feel normal and functional. And so asking them to stop may feel like a very unreasonable or tall order. I would also point out the green part on the side. Abstinence is absolutely possible. We see it regularly. I can think of many examples of people around me that have achieved it. It takes time and hard work. In many cases, it takes years of work to get there, but this is absolutely a treatable disease. And then on the right, you'll see relapse there. And that's another real part of this disease process, and one that we really have come to realize is a fairly normal part of this disease. It's not uncommon. We don't wish it on anyone, but it does happen. And it's to some degree to be expected, and it is really a normal part of this process. Next slide. So we wanted to go through some specific examples of harm reduction. Certainly, there are other forms of harm reduction out there, but these are the 5 that we'll talk about. So needle exchanges or syringe exchange programs, Narcan or naloxone distribution, fentanyl test strips, medication-assisted treatment, which is increasingly known as medication-supported recovery, which we'll also talk about, and then supervised consumption services. Next slide. So the first example would be kind of the classic example of harm reduction, which is a syringe exchange program or needle exchange. So these had their inception in, I think, the 1970s and 80s in Europe in response to the HIV and AIDS epidemic, and they've been are pretty ubiquitous now across the country. We do have a harm reduction program here in Deschutes County, and the photo on the left here was pulled from a now admittedly relatively ancient article. I think it's from 2016. From our local Deschutes County syringe exchange program. So the photo on the left is a photo of what your client or your patient may leave with when they leave the harm reduction site. So it is clean supplies to a great degree. So needles and clean cottons and a clean tourniquet, maybe a clean cooker, alcohol prep pads, antibiotic ointments. It looks like maybe some condoms there in the lower right, and some other materials. So these do still exist and are an important service in the community. Next slide. Just for your information, for those of you that are local, they do continue to have their harm reduction clinics. So every Wednesday in Bend for 2 hours, I think from 9 to 11 at the church, the Methodist Church downtown, and then on Thursdays in Redmond from 2 to 4 at the Deschutes County Behavioral Building. So they're there every week seeing patients. Next step, or next slide. I want to emphasize to you that this is not just about picking up supplies. This is about a touch with a group of folks that are trying to connect and educate and refer folks to services as needed. So it's more than just syringe exchange services. They are, and supplies. They are doing HIV and hepatitis C screening, so they have a quick finger poke test with instant results that they're trying to start getting people screened on a fairly regular basis, so every 3 months or so. They're offering vaccine clinics. They're also, again, providing education and referrals to other resources here in the community. They have a collaboration with Mosaic Medical, so their van is there on site providing primary care. So it's much more than just picking up syringes. It's really, again, a touch or an ability or an opportunity to interface with these clients or patients. Make sure that they're aware of what resources are out there and send them off as safely as possible. Next slide. Just the last piece of this would be that there are also 3 used needle drop boxes for those that might need to know, so you can pass on to your patients. There's one downtown, one in Northeast Bend at the Department of Health building, and then there's one up in Redmond, and this is a safe place to dispose of used needles. Next slide. The second example of harm reduction is naloxone or Narcan. So Narcan comes in a couple of different forms. The upper right, you'll see the nasal spray, which is what we prescribe most often at Best Care. So it comes in a 2-pack of these single-time use nasal sprays. You just depress that center button and the medication is released each nasal inhaler contains 4 milligrams. And then the lower right is an injection kit. So it also comes in this intramuscular injection form, so you can assemble this kit and administer it that way as well. Narcan is covered by Oregon Health Plan. They will pay for it, I think, 3 to 4 times per year. I can't remember the exact frequency. That you can't refill it monthly, but you can refill it periodically for free. It's also available over the counter in Oregon, which I didn't know until recently. It does not require a prescription. It does require just a quick consultation with a pharmacist to make sure they understand how to use it. It's not cheap. What I found was that it was about $150, and I think that's actually an underestimate of the out-of-pocket cost. There is a coupon on GoodRx available that will drop the price by, I think, 5 to 10%, but it's a pretty nominal savings. Most patients would likely prefer that it be prescribed and covered by insurance. For the prescribers out there, we would ask you to please consider prescribing Narcan to any patient receiving any prescription opioid pain reliever, whether or not you think they need it. Please offer it to any patient that's receiving any medication for opiate use disorder. So that would include buprenorphine, methadone, but also don't forget about naltrexone and Vivitrol. Those folks should have Narcan at home. Please consider offering it to any patient with any history of opiate use disorder or a history of overdose, even if they're currently in remission. We just want them to have it at home. Anybody using methamphetamine should have it because of the risk of fentanyl contamination, which we'll talk about. And then anybody who has opiates at home, who, if there's any possibility that children might have access to them or that they might be diverted by a curious teenager, better to send them home with Narcan than not.
So we have a question.
Sure.
We have a question. How long typically before Narcan expires? How often should we fill it for patients that haven't used it?
That's a really good question. I don't know the answer. Do you?
I think they have an expiration date on them, and it's about a year.
They do.
But at every visit, if you're seeing your patients every 6 months or every 3, I always ask, do you still have your Narcan? Is it expired? I keep one in my car just in case, because I actually used it in a rest stop from somebody I didn't know. So it comes in handy, and then I try to remember to check that expiration date. So I just remind patients. The other thing is on the coverage for Oregon Health Plan. While it's covered for 3 to 4 times a year, if somebody uses theirs and needs it, you can submit a prior auth and just state used patient needs. It's just a little bit more of the paperwork hustle.
And I honestly touch on it every time. People give them away. They share them with their friends. They use them on each other. Like just keep it coming. To my mind, regardless of the expiration date, it's something I touch on every visit. I'm sure we have a box of it lying around here, and we could look to see when it expires. But I think Billie's probably right in her guess. The next slide. So you want to make sure that when you're talking to patients about naloxone, you're also discussing what risk factors they may have for overdose. So I'm remembering that opioids, in particular, in combination with benzodiazepine, are particularly dangerous and high risk for overdose. Patients who might have a reduced tolerance after a period of abstinence, so folks that have been incarcerated or hospitalized even briefly, will see their tolerance really drop and will be at much higher risk for overdose. Consideration of the source of their drugs or the substance that they're using, so purity and contamination, particularly with fentanyl, are of very high concern. Mode of administration, so certainly a patient that's injecting heroin as opposed to ingesting opiates is going to be at higher risk for overdose. Using alone is a risk factor for overdose. Other physical health conditions, particularly pulmonary disease, is going to put you at higher risk. And then anybody who's had a prior overdose is just by nature at risk for another overdose, and they should have Narcan and be comfortable with using it. Next slide. I included this slide. I promise there's very little science in this presentation, but I did include this. I thought it was interesting. This is a graph showing the varying affinity for the mu-opioid receptor of various opioids. So the bigger the number on that bottom, on the x-axis, that kappa value, the larger the kappa value, the lower the affinity for the opioid receptor. So tramadol, meperidine are over there on the right. The further to the left the medication or the drug is, the higher the potential affinity for the opioid receptor. And you can see that the bar is pretty wide. There's a range there, but some clearly tend towards the left as opposed to the right. Fentanyl in particular is pretty far to the left, I'm sorry, and has the potential to bind very, very avidly to that receptor. Naloxone itself has a binding coefficient of somewhere, the literature varies, it's somewhere between like 1 and 2. It looked like maybe 1.5 might be a relatively accurate guess. So you can see that falls a little bit to the left of the center there. There's no such thing as a Narcan-resistant opioid, but just be aware that there may be situations where a patient requires more than one dose to free up enough of those receptors. Next slide. It's not just enough to prescribe naloxone, to reiterate the importance that you're training people how to use it so that they can go home and say to their friends and family, this is the Narcan, this is where we keep it, this is how to use it. So they need to be talking to the people around them about how to use it. And I think this is also just a good reminder for those of us as providers who may not be using it that often or have that much experience with it. The first thing to do would be to, obviously, we'll need to distinguish between whether the patient is just very high or truly experiencing overdose. So that would require really taking a look at the respiratory rate in particular. A verbal stimulation or really, really screaming or yelling at the patient. I'm worried about you. Can you wake up for me, to see if you can get a response? The next step would be to apply some physical stimulation. So a good sternal rub to see if you get any response. Next step would be to administer what's called verbal Narcan, which is to yell again at the patient. If you don't wake up, I'm going to Narcan you, and see if you get any kind of response there. If nothing, then go ahead and administer the Narcan. Remember that this is really a passive process. The patient, in theory, is not breathing. You're just administering medication to the mucosa of the nasal passages and the sinuses. But insert the tip of that nasal inhaler as far as you can and depress the button to release the medication. It's going to take potentially 2 or 3 minutes for it to start working. So the patient may need rescue breathing in that time, and that's, I think, an important thing to convey to people. And that if there's no response after 3 to 5 minutes, you should go ahead and re-administer Narcan. Narcan will bind anywhere from 30 to 90 minutes. I found varying information. Generally, you want to sit with the patient and observe them for several hours afterwards, 3 hours, I read. And bear in mind that after that, the naloxone dissociates from the receptors. There may still be long-acting opioids lingering in the system. Methadone in particular, with its half-life, can predispose people to recurrent opioid toxicity or basically repeat overdose. And so there are some cases where patients will need prolonged monitoring, repeat doses, and in some cases even IV, like a Narcan drip or naloxone drip. The last piece of it would be to acknowledge that the patient's going to wake up really uncomfortable and want to use pretty quickly, and that would be the worst possible thing to do. So really trying to redirect folks and asking them to refrain from using so that they can reduce the risk of another overdose. Next slide. So this is local data from Deschutes County, and I want to pause here and give credit. Lori Hubbard, who is the prevention coordinator, and Ashley Jones, who is the overdose response coordinator, graciously handed over this slide, to which I did nothing. They've compiled all of this data, but it's interesting, and I think it offers some interesting insight. This is information that they gathered through the Deschutes County Harm Reduction Program. This does not include information from retail pharmacies or from the emergency room or from any other sources. This is just the patients that they're interacting with in the community. So you can see data for 2019, 2020, and 2022. Or sorry, does it say 2022? No, sorry. I need reading glasses. 2021. So we have the number of naloxone doses that were distributed, the number of overdoses that were recorded, and the number of naloxone doses that were administered to reverse those overdoses. So a couple of areas or things to point out here would be, not terribly surprisingly, there's a clear increase in the number of overdoses recorded from 2019 to 2020, which was a memorable year for us all. So increased from 45 to 65. overdoses. They distributed more naloxone. The interesting piece of information here would be to note that their services were really, for much of the year, very reduced or shut down because of lockdown. So they had actually a lot less contact with the community and with patients, and still they delivered more and handed out more Narcan and recorded more overdoses. So I'm guessing those numbers are a little bit of a underestimate a little bit the gravity of the change over that period. The other interesting, so you'll see a further increase in the number of overdoses recorded from 2020 to 2021, the increase in 35% from 65 to 88 overdoses total. Interestingly, the number of naloxone doses required to reverse those overdoses jumped by 72%. So, almost twice as many as relative to the year prior. So what this would suggest is that either people are, their tolerance is a lot lower, or more likely the drugs that they're using are much more potent or stronger. And I think fentanyl comes to mind there. Of note, so the 88 overdoses in 2021, only one of those was fatal. The rest were not. 3 of those overdoses, I think it was 3 or 4, were noted in patients that were only using methamphetamine. So there, no other intentional use of an opiate, and they still overdosed, which speaks to the fentanyl issue. And then this was not super surprising to me, but I think good to point out that 75% of these overdose events did not involve calling 911. And this is consistent with what we hear in detox. I always ask about prior experiences with overdoses. 911 is often not called or involved for clear reasons. People are wanting to keep their use private and limit any potential involvement from law enforcement. So a lot of this is happening out in the community and not necessarily going to be on the radar of EMS or emergency rooms. Next slide. The third form of harm reduction is going to be fentanyl test strips. Hopefully I don't have to convince you that we have a problem with fentanyl. We broke through a terrible ceiling in April of this year. So the United States recorded over 100,000 drug overdose deaths from April 2020 to April 2021, which was like a 30% increase from the year prior, which is just unbelievable. And Oregon data reflects similar numbers of somewhere between a 30 to 40% increase. The graph here on the left is recent data. It spans, I think it's like July of 2019 to the end of 2020. If you can see, I know it's hard, the light blue bar and the dotted line represent the number and the percent of deaths involving illicitly manufactured fentanyl on the West Coast. And so you can see that those numbers, this is again just in like a 1.5 year period, those numbers are rising steadily. The other line, the solid line, represents the South. So fentanyl did make a relatively late entrance onto the scene on the West Coast, but you can see it's here, it's rising, it's really following kind of lockstep with other areas of the country, and we expect it will just continue to rise. The table on the right is Oregon data from 2009 to 2019, and that's the number of deaths involving fentanyl. I couldn't find the more updated graph, but from reading, it sounds like the number of deaths in 2020 was double that of 2019. So if you can imagine even a further spike upward, if we could push that graph out one more year, and all signs point to continued issues with the fentanyl. This is going to continue to be a problem. Next slide. Fentanyl, as you know, is somewhere between 50 to 100 times more potent than morphine. Again, I've said it several times, but it may require multiple naloxone doses or even IV administration. Fentanyl has been associated with a condition called wooden chest syndrome, which I've never experienced. My impression is that this is happening, more often in the inpatient setting where patients are receiving fentanyl as in the setting of anesthesia, but instead of not just respiratory depression, but actual temporary paralysis of the muscles of the diaphragm, the chest wall, the trachea, resulting in just respiratory failure. So it's terrifying. Fentanyl is absolutely here. We're seeing people who use heroin, who use meth, test positive. It's certainly laced in those products more and more. And then what we're seeing a lot of in the last year or two are these blue tablets that are here everywhere. They're coming largely from China, from Mexico, to a lesser degree from India, and they are passed or billed as Oxy 30, so they're called Oxy 30s. They may or may not actually contain oxycodone. They are pressed tablets. They often contain fentanyl in various concentrations. Fentanyl has this interesting property. It does this thing called chocolate chipping in pressed tablets, so it tends to kind of aggregate together in clumps, and so it's not evenly distributed throughout the pill. So if you were to quarter one of those pills, one chunk might contain a totally different concentration of fentanyl than the other, and one pill might vary very differently, very wildly from the pill right next to it. So it's very dangerous, and we're seeing these everywhere. Most people at this point, most people realize that they contain fentanyl, but I've had a couple of patients be really surprised and think that they were just taking oxycodone. The middle picture is I think it's a public campaign poster from Multnomah County Department of Health. So it's just demonstrates definitely all across our state. Next slide. Fentanyl test strips are an important form of harm reduction because they allow patients to test their drugs. So it's relatively easy to do, and it's been proven to change behaviors. So patients who find that their drugs test positive for fentanyl may not use. They may find another source of their drug. They may use less than they had intended to use. They may wait and use when there's someone else around. They may stagger their use so that not everyone is getting high at the same time. It's absolutely been proven that people change their behaviors in response to the result of the test. These test strips in particular, these specific strips that I'm showing, were tested or studied by a group out of Hopkins jointly with some folks at Brown University. So they compared these strips to a couple of other sort of portable spectroscopy methods for testing for fentanyl. And they found that the strips are really quite reliable. They are something like 95% sensitive and specific. They have a very low threshold for detection. It doesn't take much to trigger a positive test. They accurately identified this other list of fentanyl analogs that you see in the middle, which are, it's not just fentanyl that's here, it's all these other designer fentanyls, and same goes for benzos. It's just, we can't keep up. Every month there are new additions to the list, but these strips do seem to identify a lot of these analogs or cousins of fentanyl. They are cheap too. They're about $1 a piece. There's some caveats, which I'll come back to in a second, but they were initially designed for use in urine, but they can be, again, they're used to test drugs. And so patients should be instructed to drop your syringe, add a little bit of water to the cooker and dissolve any residue there, dip a strip in, wait 15 seconds, set it aside, wait 5 minutes, and then read the result. So one line indicates that there is fentanyl present, 2 lines means none. The caveats that I'm coming back to now would be that these strips are illegal in some states. They're considered drug paraphernalia. You cannot possess these in the state of Pennsylvania. I read 2 days ago in the news that Wisconsin is making efforts to overturn their rules about this, but people can't use this access or this resource if it's illegal, or it makes it much harder. So that's a real clear barrier. They're also not yet CLIA waived for any clinical use. So really, clinically for a provider, either in addiction medicine or primary care, it's not something that we really can use. We're not allowed to use them, I'll say that. So those are some issues there. Anyways, I think that's all I have to say about the fentanyl test strips. Next slide. The fourth type of harm reduction would be medication-supported recovery. So methadone is I'll spend very little time here. I'll admit I don't have as much experience with methadone, but I'll say that it is the oldest FDA-approved for medication for opioid use disorder. It's a great drug and really the right choice for a lot of people and has been life-changing for many, many people. It's a long-acting, full opioid agonist. You can begin it without delay. There's no concern for precipitated withdrawal. It has to be administered through an OTP or an opioid treatment program. So while you, as a primary care doc, can prescribe methadone for pain, you cannot prescribe it for opioid use disorder. it has to come through an OTP, and that comes with more structure. So patients, may be asked to come in daily for the dose initially, and that may kind of loosen up over time, but it does definitely create a more structured treatment environment. QTC prolongation is something to keep an eye out for. So generally, providers will get a baseline EKG before starting it. But I think that's all I'll say about methadone.
Real quick, Dr. Harvey, on the previous topic, Gary Plant wanted to know, how do patients obtain the test strips for fentanyl?
So they are handing them out through Deschutes County through harm reduction. You can order them online. You can order them on Amazon. I don't know of a consistent source of large amounts. In fact, what I know is that Deschutes County is just putting a couple of them in with the Narcan, so you can imagine how quickly people would go through those. But they can be purchased online. I don't know of any other local clearinghouse for those right now. Move to the next slide. So the other form of medication-supported recovery that we'll talk about is buprenorphine, and this is what Billie and I are working with. And I'll just speak very briefly about the buprenorphine. I'm sure you know more than I give you credit for. So buprenorphine is, again, a partial mu receptor agonist. It is prescribed to treat symptoms of opiate withdrawal and to manage cravings. Because it's a partial agonist, it does have what appears to be a bit of a ceiling effect, which reduces the risk of respiratory depression and overdose. It's also a kappa antagonist, so it prevents dynorphins, which are chemicals that drive a lot of stress, anxiety, and cravings to use substances. We generally, the goal is to give the patient the minimum effective dose. So you want to, you don't want to go over any higher than they need, but you want to manage symptoms well and keep people comfortable. In theory, generally you would go up to 24 milligrams, but there are some patients that might require a little bit higher dose. So occasionally you'll come across a patient who's taking closer to 30 milligrams. Billie pointed out in our conversation as we prepared for this that patients that are struggling on those higher doses may need to be referred for consideration of either methadone or the injectable extended release form of buprenorphine. The buprenorphine comes in several different preparations. So the one that most people have heard of is Suboxone, which is a combination product. Contains both the buprenorphine and naloxone. The naloxone is added with the intent that it acts as a deterrent to prevent people from injecting or snorting this medication. In theory, when a patient takes the Suboxone correctly and melts it under their tongue, very little of that naloxone gets absorbed systemically, and it's really supposed to be considered kind of an inert product. I will say that I recently had an interaction with a clinical pharmacist who indicated that probably some of that naloxone is absorbed systemically, a small percentage of it, but enough. So if you have a patient who's complaining that they feel pretty crappy for the first half an hour or so after they take their medication, there may be something to that. Suboxone comes in both tablets and strips in several different denominations. The medication is melted under the tongue briefly, after which actually the residue can be removed and spit out or swallowed, whichever the patient prefers. Buprenorphine also comes in as a monoproduct called Subutex, which comes in tablet form only, and this is generally the preferred medication for pregnancy because that is the medication that was studied in pregnancy. And then it comes in a long-acting extended release injectable form. So Sublocade, as pictured on the right, comes in a couple of different doses. It's injected into the fat at the abdominal wall. It's an interesting drug, and it's a REMS. It's got some REMS regulations surrounding it because when it makes contact with the liquid or the fluid in your body, it solidifies. So it turns into a nodule, a hard nodule that your body will break down over time. And the concern is that in the wrong hands, were this to be injected into a vein or an artery, it would immediately embolize. And so there are some stringent regulations surrounding the medication. It really has to be delivered directly to the provider who will then administer the medication. I think that's all I have to say there. Next slide. A couple of just quick considerations about the buprenorphine, and we're going to talk more. I'm going to let Billie talk more about these topics, but that generally, because the buprenorphine is a partial opioid agonist and because it binds pretty tightly, there is the potential to precipitate withdrawal in a patient that has opioids on board. So generally, you have to wait till the patient is kind of well into the withdrawal process before starting it. Patients that use fentanyl regularly pose a particular problem because fentanyl is very lipophilic. Folks that are using enough of it often enough will have stores of it in their body fat that are leached out into the circulation over time. And so your patient who hasn't used fentanyl and it is clearly withdrawing may still have enough receptor activity and saturation that if you dose that buprenorphine too soon, you can actually make things worse. And so that's a consideration. We generally try to wait closer to 48 to 72 hours, but that, as you can imagine, is really miserable for the patient. Microinduction is a really interesting concept, which can be done is an outpatient procedure where you basically start the buprenorphine in such small doses that you really creep up on the receptors and saturate them so slowly that the patient doesn't notice. And they actually can continue to use their opiate for the first 7 days of that treatment before stopping. So it's requires your patient has to be pretty savvy and be able to follow some pretty specific instructions, but it's a really interesting approach, and we've had some good success with it. Concurrent use of benzodiazepines and alcohol, which I'll let Billie speak to. We've already talked about the monoprofit product and that it's preferred use in pregnancy. I'm realizing this probably should have gone. Billie, I'll let you talk about this, but we will often meet patients who ask specifically for the mono product as opposed to the duo product for various reasons. We're seeing that the DEA is watching prescribers and prescribing practices. It sounds like it's about a 15% threshold that they've set. So prescribers that are giving people a lot of buprenorphine, the mono product as opposed to the duo product, are receiving increased scrutiny, and pharmacies as well that are placing large orders for buprenorphine, the mono product, are also facing increased scrutiny. So it's a really interesting environment to be practicing in right now. Next slide. Supervised consumption services, I'll just touch on really briefly. This is basically a place where you can go and use safely and be monitored, and someone will administer naloxone if you need it. The site on the left is I think it's been there since 2006. It's in Vancouver, BC. It's a long-standing supervised consumption site. More recently in the news, this last fall, New York opened these are the first in the country, 2 sites there. Very controversial, very interesting. They, on the first day, I think by 2 p.m., they each had 40 visits at each site, and they'd reversed 2 overdoses. So certainly a point of controversy for folks who live in the neighborhood, but in theory, this is a place where someone can come in, safely use their substance under monitoring in a clean environment, dispose of things appropriately, and then move on with their day. So that's kind of an interesting concept. Next slide. So then just a couple slides about talking to patients about these topics and some tattoo inspiration if you need it. Next slide. I think I want to really take a minute to talk about stigma and call out that these patients, everything they do, every moment of every day is filled with stigma, and that we're all part of that. And I think we need to at least recognize it. So society's decided that people that use drugs have no willpower, they're lazy, they're deviant, they're criminals. When bad things happen, they deserve them. They're not motivated to change, and they never will. They're pill shopping or doctor hopping. Common conception is that zero tolerance is the only solution, and that you have to let people hit rock bottom, so to speak, and which is contrary to harm reduction, in that harm reduction again meets people where they are and will meet them over and over and over again until they're ready to enter into treatment, but would never abandon a patient or just kind of send them out to spiral on their own. It just offers continual, repeated efforts to get, or opportunities to get into treatment. It's misconception that people won't be honest about their drug use, and that you're going to have to get a UA to get any kind of honest answer, that you have to do that to fact check or to confirm what they tell you. And then this idea, this is a hard one, that this idea that people who have substance use disorders are not able to parent safely. And in many cases, certainly that's very true. We've seen a lot of really sad cases, and that is the hardest part of this job, easily. But I can also think of many other cases where it is possible, And I can see that where patients can parent safely and have a concurrent substance use disorder. So these stigmas people are very aware of all of these forms of stigma, and they absorb a lot of them. I've never seen so much self-loathing in a patient population. Many times they feel like they don't deserve treatment. They're very down on themselves for when they find out that they've got hepatitis C or other associated sequelae. It's just heartbreaking. I will say that. So just keep that in mind as you start these conversations. Next slide. So starting the conversation, my suggestion would be to really call it out at the beginning, at the outset, and say, I get that this may not be your priority. It may not be realistic to ask you to just stop. You may not want to stop. I'm not asking you to go to treatment. Next slide. The other piece of this, what you want to be doing is offer consistent and clear communication, again, about your role, who you are, what you do, what you can offer. Don't take it personally when they're not asking or not taking you up on your offer. Understand that they may be back at some point, referring them out to other providers as appropriate, and remembering that it may have taken a lot for your patient to even show up. They're feeling vulnerable and defensive and have all kinds of other barriers. Next slide. A word about word choice. So promoting engagement, it does involve choosing your words wisely. And so I've put on the left a list of words that we're really trying to move away from, or terms that we're trying to move away from because of the associated stigma. And I put on the right an example of what might be more appropriate or acceptable language to use. So instead of calling someone an addict, you would say a person in active use. Someone is not addicted, they are dependent. They're not an alcoholic, they're a person with alcohol use disorder. This is a big one. Abuse is a word we would love to just kind of stamp out completely and replace with words like use, misuse, or dependence. Clean and dirty are two commonly heard terms. So a clean UA is instead a negative UA or a consistent UA. A clean person is an abstinent person or a person in remission or in recovery. A dirty UA is a positive test or an inconsistent test. And that your patients will use the terms on the left regularly, but we really try to use the terms on the right they're, again, associated with much less stigma and I think are more respectful. A baby cannot be born addicted to a substance, and addiction is a behavioral health issue and that a neonate is not capable of possessing or engaging in. Instead, the baby was exposed in utero, the baby was born to a mother who used substances, or the baby has signs of withdrawal would be more appropriate language to use. And then probably the least intuitive would be, everyone is used to hearing medication-assisted treatment, but the more PC term increasingly is medication-supported recovery. Medication-assisted treatment gives too much credit, we think, to the medication and not enough to the efforts of the patient. The medication is not a silver bullet. It is it facilitates and contributes to recovery, but shouldn't be given all the credit there. So medication-supported recovery is the preferred term. Next slide. The nonverbal cues that you use with all of your other patients are just as important, if not more so, with this patient population. Making good eye contact, listening actively, trying not to chart or document in front of the patient, manage your responses and facial expressions because people are going to tell you things that will surprise you and sometimes horrify you. Being mindful of what you're doing when the patient enters the room, so making sure they know you're glad to see them, you're expecting them, you have time for them. This is going to be a meaningful visit. And then looking at your physical environment, so to see what are on the walls, what kind of posters or supportive documentation do you have on the walls? Where are the doors? Does everyone feel like they have easy access to the exit? Are you both comfortable? Is this a private space? Make sure that there are not people coming and going. All of these things are really important. Next slide. Some specific talking points or suggestions for how to approach these individual patients. The graphic on the right is very helpful to think about patients in terms of risk, set, and setting. So risk refers to the actual substance that they're using. So whether it's heroin or methamphetamine, those come with very different risks. So factoring that into the conversation. The set involves looking at what the patient brings to the table in terms of their mindset. So how is their mental health? What other diagnoses are they struggling with? What's their housing situation? What's going on with their marriage, their transportation, work? All of these things contribute to the mindset that the patient brings to the substance use environment. And then the setting refers to literally asking about the setting. So where do you use? You want to know, is it in the car? Is it under an overpass? Is it in a place where they're exposed to the elements or law enforcement? Do they have access to clean water? Are there people nearby? Are they safe people? And are they people that can help in the setting of an emergency? So touching on all of those pieces. A couple of other talking points, again, would be to ask patients, making sure, I want you to know what your tolerance is, especially for folks that have been abstinent recently, so that people have a sense of how much they can use before they start to get into trouble. Encouraging people to be familiar with the supply of their drugs and to test their drugs. Asking people, do you feel like you can control your high? You can always use more, but you can't use less. Do you feel like you have that under control? Talking to patients about the risks of mixing drugs, encouraging them not to use alone or to have someone check in on them, staggering use if they're in a group, making sure that they have a plan and communicating well with the people around them are all points to hit in these conversations. Next slide. So putting it all together, we want to make sure that you're using that preferred language, asking open-ended questions, really understanding the story, taking the time to hear about what's going on and what's truly happening. And, literally, how are you? When are you using? How are you using? Have you ever overdosed? Are you familiar with Narcan? Believing in self-efficacy, so asking patients what worked for them in the past and believing and taking that to be truth. Asking them what they perceive their greatest risks to be, and ask them, do you feel like you have this under control, or what can we do to increase the degree of control you have over this situation?
I'm just going to add from the comments, Deborah Feisick said, this is great terminology, definitely less threatening or accusatory to the patient client as well as the general communities. And I think that's really important to note. I've had patients thank me for correcting their terminology when I explained to them, this puts you as a bad behavior as opposed to somebody struggling with a chronic disease. So thank you, Deborah, for recognizing that.
Yeah, it's also just, it feels so much more professional. Makes me feel like I've grown up. So, and then the last two pieces would be, in doing all this research and reading and thinking about all this, the themes that kept coming up were trauma-informed care. So again, remembering that your patient is a product of all those prior experiences and their current experiences and their current situation, and motivational interviewing. So this is really glorified motivational interviewing, where you're asking the patient to identify the problem, identify some barriers, decide what what success is or what a goal is, and letting them kind of lead that conversation. Next slide. A couple of just parting cautions. One would be to be careful not to spend too much energy focusing or praising abstinence in particular. As we talked about earlier, abstinence is the goal, and it is absolutely a reasonable goal to have and one that's achievable. But relapse happens. It's a part of the disease process. People are devastated when they relapse, and you can feel it and see it. And so focusing more on the process goals and behavior changes and not so much on the outcomes is really important. Billie and I liken this to, it's like if your sister finally breaks up with that guy that you all hate, the whole family hates, and you all are honest and say, we hated that guy. And then before you know it, they're back together and engaged, and it's just uncomfortable for everybody. So it's that kind of just appreciating the process and not getting too focused on abstinence per se, and just offering support and letting the patient guide that conversation. And then the other piece of this would be balancing autonomy. So giving people autonomy and saying, I believe in you, you can do this, you can make this change, but also allowing them to have a chronic disease, which are two kind of opposing messages, I think. One indicating that they have control, and the other indicating that this is something that's happening to them. And so that's kind of a dance too, something to keep in mind. Next slide. I think this is my last slide. So just some misconceptions that providing needles are a safe place to use will promote continued use. Giving people Narcan just allows them to engage in riskier behavior because they have that Narcan in their back pocket. The data show otherwise. There are communities that have access to harm reduction services have seen a reduction in their HIV and hepatitis C infection rates by 50%. People with access to harm reduction services are 5 times as likely to enter into treatment and 3 times as likely to ultimately achieve abstinence. Opioid overdoses are far more successfully reversed by folks that are trained to use naloxone than the general public, so 80% success rate. And then this is a more recent study. It just came out this last October that from a 2019 study. 75% of people using buprenorphine are using it appropriately and not diverting it, and that misuse is really trending downward. So there's this misconception that people are going to misuse or divert their medications, but the data don't seem to suggest that. So all told, yes, it does seem to work and help. Next slide. Okay, now I'm going to hand it over to Billie to talk more specifically about some of the challenges that we see in practice.
Okay, well, thanks, Dr. Harvey. I feel like she did a lot of the work for this, all the slides, and definitely the harder part of this talk. I'm also going to give myself an own plug. I very much was excited to have Dr. Harvey and putting in her head to go the route of getting Addiction Medicine Board certified and joining me at Best Care. So she's such a welcome addition to work with. I'm really glad to have her. So back to the slides. I don't have to look at myself in big print. Harm reduction in practice and challenges for providers. I'm just going to talk very frankly, and a lot of this, my personal experience, as Dr. Harvey alluded to at the beginning, when I had my waiver training, and just even going back years when I wrote my master's project, graduating from Duke, I wrote it on buprenorphine, and it was just very personal to look into that just because of a family member and discovering, oh, there is actually something out there. Well, I was very much thinking it was a magic bullet, and that once that I was able and authorized to prescribe this, I would have this for my patients and they would all be cured and it would be easy. Well, 4 years into doing this, I can tell you it has not always been easy. There are cures, and it's unfortunately not magic. So just speaking about buprenorphine is a treatment for opiate use disorder. And I think that's very important to acknowledge because it makes a huge difference in patients struggling with opiate use disorder, but that doesn't mean that they won't have other struggles or still have some struggles with opiates. And that reason why has to be approached in the same way you do other chronic diseases. When we look at how we practice with insulin and diabetes, we used to withhold insulin until late. Now that has very much changed, but it's still not a cure-all. And people may struggle with active, poorly controlled diabetes in spite of appropriate medications for diabetes. And it's the same with opiate use disorder. We unfortunately do not have a good medication to offer for stimulant use disorder. And currently what's most effective is cognitive behavioral therapy, but patients have decision-making processes in engaging in treatment. And we very much work from a medication first and encouragement and motivational interviewing. And some people aren't ready to address their stimulant use disorder in spite of stabilization on their opiate use disorder. And it's important to meet patients where they're at and acknowledge that, this is a process. And somebody may do very well with their buprenorphine and not use any opiates, but still struggle with stimulants. And that's not a reason to stop their buprenorphine, but we see it happen all the time. What I do clinically is, really more of a conversation of what I can offer patients, smaller scripts so that I have less concern about diversion and more frequent visits. So I have those opportunities to interface with patients. I also, if life is very chaotic, may offer long-acting buprenorphine the same way I would offer long-acting birth control to somebody that may not be able to manage a daily medication in spite of a very effective daily medication. When it comes to alcohol use disorders, much the same way we're able to ignore in primary care or internal medicine, and I'm not just saying ignore, but what we don't know doesn't get discussed. We prescribe control medications for patients. We tell them don't take alcohol with this medication, whether it's their pain medication that they take for some chronic non-cancer pain or even for cancer pains, but that doesn't mean they don't ever use alcohol. And while it is a concern that alcohol can be riskier for patients on any opiate, including buprenorphine, it's not an absolute, and it's not always a reason to stop an effective medication, and really being able to sit in this place of, will the decisions I make as a clinician cause more harm if I continue, or will they cause more harm if I stop? And so that's the question I ask myself when I'm faced with these polysubstance abuse situations, and trying to figure out how I can help the patient navigate their care plan and what else can be offered to help them be in a place where they're safe and they're on their personal journey of recovery, not what I think that journey should look like. And it very much is likened to conversations I had with diabetic and hypertensive patients where this is what my clinical recommendation is, and what the patient did was often different. So staying in that place of being humble, making sure I'm not harmful in my decisions. And so if I'm prescribing medications and it gets uncomfortable because I think that I may be causing the patient more harm, that's when I may consider a referral to a different, like an opiate treatment program where there's at least safety in coming in every day. Or, I may taper somebody off of a medication because it's not effective. And it isn't effective if they're not taking it, or they're taking it in a harmful way. Getting back to buprenorphine is not a silver bullet. You have to consider external stressors, trauma history, socioeconomic factors. Those come into play. And, what success looks like is very person dependent. I know we see this with diabetic patients. There are patients in past where I celebrated an A1C of 8 because it was a long time coming. And just as Dr. Harvey talked about earlier in that spectrum, there's a spectrum for where somebody is in their journey of recovery from a substance use disorder. And that leads back to that. With a patient that continues to use, would you withhold insulin for a poorly controlled diabetic? So it's working with the patient, continuing medications that are helpful, and really getting into that space where you're able to make decisions on, what would be more harmful. Concerns for diversion do come up. And when we talk about what happens with diversions with buprenorphine, in the 4 years I've been doing this full time, I've run into one patient that was abusing buprenorphine and injecting buprenorphine. I've run into frequent where they traded their buprenorphine for other more effective substances to get high. And, it's not something I want patients to do. And we have discussions in our buprenorphine treatment agreement as far as using your medication, not selling, not trading, but we know it happens. However, most of the data shows that buprenorphine that is diverted into the community, and this comes up frequently when I meet patients, and do you have familiarity with buprenorphine? Yeah, I got it on the street, or I got it from a friend, or somebody gave me some when I was in jail so I wouldn't get sick, and somebody not being the jail. So that's often what we see as diversion. Frequently, I get requested has Subutex versus Suboxone, and a little piece of me wants to invite the DEA to the table for a conversation. Like, I wish I knew a way to call them up and like, hey, can we talk about this? And I'm not trying to invite a visit for myself, although that may happen and I'm aware of it. But my first question would be, seriously, we're worried about Subutex versus Suboxone when we have fentanyl, and don't even get me started on kratom. But Buprenorphine is the active ingredient in Subutex. It's the active ingredient in Suboxone. As Dr. Harvey stated, there is a small part of naloxone that is active in Suboxone, and patients may get sick. And if taking Suboxone makes them so sick that they don't take it, I believe my patients. I document well, I explain to them the DEA concerns, I prescribe Suboxone, but if they can't tolerate it, I document that intolerance, and that's my approach. Not every provider may be comfortable with that. I don't think my numbers are above 15%. I try to be very cautious with this, but what I hear all the time is this misperception with prescribers and criminal justice and other people that Suboxone keeps people from using and Subutex doesn't, and that's not correct. Buprenorphine is the tight binder most people are not using on top of their buprenorphine product, whether it's Subutex or Suboxone. And what makes the diversion, what was put in Suboxone, the naloxone in Suboxone, was so people don't snort and inject it. And most patients are not snorting it or injecting it anyway. I'm going to read real quick. As methadone is used for opiates, benzos, and E2OH use, has anyone looked at pharmaceutical amphetamines for stimulant meth abuse? Gosh, good question. And I asked this at a OHSU ECHO, and I know that there was some studies on the narcolepsy medication. It's got limited case studies. There's not solid evidence-based support for use of amphetamines for stimulant and meth abuse, but I believe there are ongoing studies. And somebody's posting a link to look at it. Anyway, patients taking prescribed benzodiazepines. That's not always an absolute no to buprenorphine. That is a conversation between both prescribers about patient safety and efficacy of the medication and risk. I have only had a situation where I was the prescriber of a benzo in a patient that was taking buprenorphine when I was helping the patients taper off of benzodiazepines. It's not comfortable, but like any medication you prescribe that may have risk with interactions, it's just a conversation both prescribers should have. It's often more harmful to make an absolute no, because full agonist opiates, fentanyl, heroin, when abused, is going to be more harmful combined with benzodiazepines than buprenorphine, but that doesn't mean it shouldn't be a conversation. There is at least one patient in my practice that gets 10 clonazepam a month. I encourage them to not use them, but they're still my patient, and sometimes they still take their benzo. And so it is sometimes appropriate. It's a conversation that both prescribers should have as far as risk reduction. Perioperative prescribing. So this is something I think we've come a long way in Central Oregon compared to where we started. When perioperative prescribing occurs, patients require surgery, they're on buprenorphine. They used to get told, you have to stop your medication 5 days before your surgery. And it was just the blanket answer. That's harmful to patients, and that's risky for their recovery. And we know now that buprenorphine can be effective for pain management. It does make any patient on opiates, it's more painful to manage their pain. It's more challenging to manage their pain, and maybe more painful. It's more challenging. It's a conversation that should occur between the surgeon, anesthesia, and the buprenorphine prescriber. But there's a lot of help out there. Oftentimes, just reducing the dose a little bit for patients that are on high-dose buprenorphine is very helpful. And then just continuing where they're safely at is often the right answer. And what can be very helpful is calling the provider line and asking for OHSU's impact team, because they have done a lot of research, have a lot of data, and a lot of specialists in helping navigate this. For my patients, I use a buprenorphine prescriber letter to send to their surgeon and anesthesia teams. This patient is on this amount of buprenorphine. I'm their prescriber. These are their standard recommendations. And here is the OHSU impact team, as well as my number, if you'd like to collaborate more about this conversation. I will briefly touch on tapers. No patient has to taper unless there's this question of harm. But tapers should be long and slow. What I found most successful is they're patient-directed. And by that, I mean the patient is the one who states, I want to taper. And when somebody comes to me and states that, I just ask some questions about, what brings this up? Or is this something you want for yourself? Or is there somebody else in your life that is driving this request? And then we have a conversation about risk and benefit. I often, with patients that are at 24 milligrams of buprenorphine, because it took that to stabilize them, say, we can easily, after 6 months, a year of stability, get down to 16 and then see how you feel. And then I'll go by 2 milligrams every 2 to 4 weeks, and they can stop at any time. I have patients in the process of a long taper to come off of buprenorphine, and they set the pace. I've just found that the slower we go, the more successful it is. Next slide. So additional external pressures. Data waiver training requirements have been off-putting for people to jump in and become a buprenorphine prescriber. I guess in my perfect world, we'd have data waiver training for every controlled med, because I think I benefited from the knowledge I gained in that training. But unfortunately, it is a barrier for some. So instead of the training being good, the medication's bad. And that's very unfortunate, because the training was very helpful. And I think early in my career, I could have used more training about the risk of opiates, the risk of benzos, and it is unfortunate, but we acknowledge that data waiver training sometimes puts people off when it shouldn't. PDMP provider reports, they've been a game changer in doctor shopping and understanding what's out there. But if you go look yourself up and you're in addiction medicine, your little red line's kind of high. And that can not feel good, instead of just saying, am I clinically doing the right thing for my patients? And so those can sometimes be challenges for providers to look at themselves compared to others and step back and have that reflective, am I doing the right thing here? And that answer may be yes, maybe no. Then these DEA pressures, like I said, sometimes I invite the idea of this collaborative conversation, because I really appreciate that the DEA has a hard job, and they want to decrease harm in our communities and all of the legal things. But we also have hard jobs, and it would be great if there was more of a collaborative relationship about simple things like Suboxone versus Subutex, and why somebody like me really wishes Kratom wasn't available at 7-Eleven, because I've seen the harms it causes. Okay, so yes, Laurel Hansen, the X waiver training. Excellent point. You can prescribe to 30 patients without the training. You still have to get the X number, just so people know. You still have to apply for it, but you're no longer required to get the training. When that originally came out, I think I went 6 months going, oh, it doesn't matter, you can just prescribe. And then I found out I was wrong, and you actually still have to have an X number. So I was thankful for the pharmacist who pointed that out to me. Next slide. Okay, harm reduction in practice and these challenges for patients. We have these conversations all the time. They're rooted in the stigma as well as the patient's self-loathing, that they may not always have positive interactions with clinicians in the community, be that pharmacist, the ER, and counselors, people in the recovery community, other medical providers. For the patients, every time they go to interact with someone, because they have their own internal judgment and because they've already run into so much judgment, there's already like, what am I going to run into now? And they already, like Dr. Harvey pointed out, never a population have I worked with has there been so much self-loathing. So trying to help patients navigate that and really recognize the disease aspect of the substance use disorder and get away from the behavior and the judgment. I can give you some examples. I had a patient that went to doing really well, and she's living in a recovery community. She's on buprenorphine, and she went to a local pharmacy to fill her buprenorphine, and they didn't have it ready. And she was told by the staff member, and I know everyone's tired, exhausted, burned out. Pharmacies are overwhelmed. But she was like, well, I need my medication. I have to get it. The patient's afraid of withdrawal. And she was told, you're going to have to wait. You're on buprenorphine because of your bad decisions. It's not my fault you're an addict. And so, those things are really harmful. I've had patients get talked about by hospital staff while they're sitting in the hallway. I hate it when those addicts come in seeking drugs when the patient was there for an abscessed tooth to get an antibiotic. So these things happen. As providers, we get exhausted. The human nature of it comes out, but these are humans seeking help too. There's a lot of external pressure on patients from family members, counselors who may have their own opinions about the pathway to seeking treatment, mutual support groups. It is not uncommon in the AA and NA community to be very anti-medication supported recovery. I honestly encourage my patients to take part in mutual support groups, and I tell them, if you wouldn't talk about the antibiotic you took for your STI, I don't think you need to talk about the medication you take as a component of your recovery. I don't think you need to share your blood pressure medicine, and I don't think you need to share your buprenorphine other than with other medical providers for you. And then clergy. Sometimes I've had patients that, their clergy have encouraged them to get off medication as quick as possible. And oftentimes education and that willingness, would you like for me to talk to this person with you, can go a long way. I give a lot of handouts to help engage in those conversations. Sober living was a bigger problem before than it is now, but it still comes up that sober living wants to dictate what medications a patient is allowed to take, which is wrong. And it's a violation of Persons with Disabilities Act, but it comes up. And then there's the availability of MSR while incarcerated. There is some lovely and wonderful data out of Delaware for their state prisons offering, patients get to choose methadone, buprenorphine, or naltrexone. And they're connected with a provider as soon as they're released, and their recidivism rates dropped precipitously. I guess it's that East Coast to West Coast slow transition. Fortunately, fentanyl was slow, but now we're getting it. But we're also getting MSR accessibility while incarcerated. I love seeing it happen. It's not everywhere, but it's coming. But it can be a barrier, an easy barrier. If a patient's on methadone and they get arrested in this county, they're going to be in withdrawal while incarcerated because methadone's not available. Okay, next slide. We're going to go over some cases. These are some that I picked and just talk about these ones that were not slam dunk or easy. And I am open to feedback and discussion. I wish that we were in person because I would be making eye contact with everybody and daring you not to talk, but now I can't look at you. So anyway, these are real patients that I have. A 33-year-old female, past medical history of opiate use disorder, alcohol use disorder. She also has a binge eating disorder with anorexia. Stable from a standpoint of her opiate use disorder on buprenorphine for 4 years. And we've had this oscillating stability, instability, where her alcohol use disorder and her anorexic binge eating disorder fight for the floor. So she's had these periods where she's worked really, really hard to get her eating disorder under control, and it's led to alcohol binges, which have led to multiple hospitalizations. Since she's been on buprenorphine, she's had no history of opiate use disorder, no history of overdose, no return to use of opiates. But the alcohol and eating disorder have been a battle for her. They put me in places of discomfort on, am I doing the right thing? What else can I do? She was unable to navigate a typical dual diagnosis SUD mental health facility because what happened immediately, she went through detox, stable on buprenorphine, eating disorder, wildly out of control, obvious, and impacted everyone else in the facility. So that didn't work. She has been in intensive outpatient services, has made, long stretches of complete stability for her, which have then, and, we've worked to try to stabilize her alcohol use disorder and say, hey, let's get you re-engaged with your counselor for your eating disorder, work with a dietitian. And this has often led to, a severe binge of alcohol hospitalization. We've tried some different things. We tried to get her on Vivitrol. Her body habitus is, such low body fat and muscle that it's not realistic. That would not. I don't know if anybody has familiarity with that, with Vivitrol, but on 2 spectrums of body habitus, it can be a problem for extremely underweight and overweight to be able to safely administer Vivitrol. We tried disulfiram. What I've done with a few patients with harmful alcohol behaviors is I will continue their buprenorphine if they will come in once a week for observed antabuse to help them manage. Disulfiram or antabuse is only effective as an aversive therapy. So to help them manage impulse and to have some reassurance for myself of safety of buprenorphine and not completely going out of control with alcohol, that we've done that. And in some patients, it's been successful. With her, it wasn't. What she ultimately discovered was that taking disulfiram, if she really got in this cycle of panic around binging, it helped her binges along with both food purging and returning to alcohol. So that became unsafe. I get told all the time, this patient needs to go to a higher level of care. I love that statement. In many cases, I'm looking for that higher level of care too. But the referral to a higher level of care cannot be a referral to nowhere. We're working hard with her insurance to find an inpatient eating disorder treatment that will allow her to continue her buprenorphine. And it's just now the insurance obstacle. But really, I would invite that questions or feedback. There's these things to consider, and then what would you do with this patient? Because what has not felt like a solution to me is to stop her buprenorphine because of her alcohol binges. So if anybody has thoughts, like I said, I welcome those because these patients are hard. And when they're your patients, it's uncomfortable. And that collaboration occurs, but then you can run up against those barriers or walls, like what is the higher level of care and how do I get this patient that access? Next slide. And at any point, if somebody wants to chime in about a case or go back to a case, I'm happy to. This is another patient that also had that combination opiate use disorder and alcohol use disorder. One of the things I educate all my patients about when it comes to the risk of alcohol is 30% of patients who stabilize on buprenorphine or methadone, and that's a ballpark 30%, that continue to dabble with alcohol will develop a full-blown alcohol use disorder. And, that's a high number. And then you have a patient with opiate use disorder, alcohol use disorder, polysubstance situation, which is even harder to manage. So this patient has stabilization long-term on buprenorphine. She was referred to me because of her alcohol use, cyclic episodes with these 3 to 5 to 10 day binges of alcohol, which were really severe and would require inpatient detoxification to stop the alcohol use. She's had significant periods of stability with this periodic inpatient admission. She developed the most success when she added residential services. So she went, after a period of outpatient, went to residential for a 28, 30-day stay, and then went back from that residential to an opiate treatment program. It was successful for a while. And then she returned to alcohol and was discharged from the opiate treatment program, came back to our detox. I agreed to take her back. That time we tried Vivitrol. That had no success at all. The patient was very much, almost to the point of begging. I felt better. I did better. I was so much better when I was on buprenorphine. Please, can I go back? I agreed to restart her buprenorphine with the combination of the once a week disulfiram. She's doing great. I don't really know how long it's been since her last drink of alcohol, but I know she's working full time, and that's the first time since I've known her, and that's been 4 years. She feels well, and she stabilized on her buprenorphine. She is a patient, I just want to bring this up, who frequently asked for increases in her buprenorphine for her alcohol cravings. And I was concerned about her buprenorphine dose as far as her alcohol use. And so I set some strict parameters about what I was willing to do, and offered her all the other adjunctive alcohol use disorder medications, to include acamprosate and topiramate, which ultimately she was successful in one. But I really tried to make clear to her that when she's craving alcohol, buprenorphine is not a solution. But that's a tricky balance with somebody with a co-occurring disorder. Next slide. This is a very common presentation. I know everybody gets them. Opiate use disorder and stimulant use disorder. This patient's been stable on a buprenorphine combo product for 4 years. Continued use of methamphetamine. I received him from his primary care provider because of his continued use of methamphetamine. We've tried many things. I've gotten to know him. I now know that his past history also includes this trauma of finding his mother overdosed and deceased in the hot tub when he was 18 years old. That's not something I knew about for the first year and a half that he was my patient. We, at the time, agreed that mental health counseling might be helpful, but he discontinued after 6 sessions, and his feedback was, the counselor's really nice. I know that I need counseling, but I'm just wasting his time. And really just indicated to me he wasn't ready to go there yet. The things to consider in this patient, first and foremost, buprenorphine is not a treatment for a stimulant use disorder. It should not be a punishment, and it should not be a reward. It is an evidence-based treatment for opiate use disorder. Opiate treatment program could be considered. Honestly, I can think of 0 reason to send him to an opiate treatment program. He's completely stable from his opiate use disorder. His only issue is the continued stimulant use. And circling back to buprenorphine is not a reward, and I'm not going to send him to an OTP as a punishment. He works, he has a full-time job, he always shows up, he'll do pill counts, he'll do a UA. We've started just recently what's called contingency management. I would encourage you to explore that. It's basically when he comes in and we ask him about stimulant use, ask him if he wants to give a UA to show us he has no stimulants in his system, and then he can spin the wheel and win a reward. And that reward could be good job. It could be a $20 gift certificate to Sportsman's Warehouse, because that's what he said was his favorite shop. But it's really been about, what does this patient want? And the patient may want, and in his case, I should also add, he uses stimulants once or twice a week. We did a thorough workup. I was sure he was going to have sleep apnea. He doesn't. I was sure I was going to find some kind of reason for his fatigue, which is that there isn't one, other than probably his deadened dopamine receptors and continued dopamine spikes from methamphetamine. And he's aware of all these things. And it's just continuing to work with him on this journey of when he's ready to consider the harm that stimulants might be adding to his life. So once again, asking the audience, what would you consider and what would you do differently in a patient like this? And next slide. This is another interesting case of a patient with severe persistent mental illness. Her substance use, mental illness, homelessness, and difficulties with attendance have made it very difficult for her to engage in services for her mental health diagnosis. She moved to this area from California. I received her from the hospital community engagement team, who asked me to see her and help her because she had had multiple hospital admissions and ER visits due to her heroin use and overdoses. She's not somebody that oral buprenorphine worked. She came in after 2 days and said, "I took it all, can I have more?" She's not somebody who's been successfully able to show up every day at an opiate treatment program. That could be considered. It just didn't work for her. We did manage to get her on buprenorphine for 7 days, and that allowed us to initiate long-acting buprenorphine, and it has been a game changer for her. She has had no further uses of opiates. She does not have an overdose. She always shows up. Sometimes very disorganized, recent use of methamphetamine. The methamphetamine is not helping her mental illness. We have tried to sit with her in a telepsych visit with a telepsych prescriber. It didn't go well. The mental health access has continued to be a barrier. Our peer mentor ensures she attends appointments. We're working on that relationship to potentially in the future allow assistance in engaging in mental health services, but the stimulants haven't stopped. I stopped getting UAs because I know what's in them. I know she's on buprenorphine. I ask her about other uses. Once in a while I'll get one if she feels like it, but it hasn't made a difference to how I treat this patient. The patient has asked me, like, how long am I going to get my injection? And I tell her, as long as you want to, and I think you should continue it. And every month she's there. So this is a case, like when I first got the waiver training and, the criteria for access, SPMI was one of those that, maybe outpatient isn't the right place for them. But that's a maybe. And in this case, our services have been right for her because it's reduced her risk of dying from her opiate use. Next slide. I have another SPMI patient who happens to be on injectable antipsychotics, doing great. I would not, it took more of a conversation for me to realize with the schizophrenia diagnosis, oh, there it is. But it wasn't like first sit down. He's well put together, working full time, very polite, always honest. He hasn't wanted to be on injectable buprenorphine. He's had some episodic return to use of heroin. Oftentimes when there's consistent use of heroin on buprenorphine, you're not at an effective dose of buprenorphine, but this patient hasn't been willing to increase. I don't know why. We have those conversations. He's had frequent use of methamphetamine. It's important to consider he has stable housing and lives independently with roommates. He's working. He's consistently taking his injectable antipsychotics. He shows up for his appointments. He doesn't want to go to residential for his job. And then I also think because of his mental illness, it might be an uncomfortable place to be. The question is, does anything else need to change for this patient? Next slide. Multiple resources available that Dr. Harvey has shared. And yes, Ian, it is okay to jump in.
That was just me reminding everyone that it's okay to jump in. That Billie,
I just was so excited somebody wanted to talk that I let you.
You're not asking rhetorically. I was just, I'm listening, and I wish I had any clinical experience to offer to you, and I don't. But I'd be thrilled to hear what others, because I know there are people who do. So, sorry, continue. It's fascinating.
Yeah. These are just slides.
Yeah, the top website is a clearinghouse for harm reduction services here in Oregon. So I think it's a grant-based. It is possible to get both training materials and, I believe, naloxone. So that's the first website. The second is the Deschutes County Syringe Exchange Program and Harm Reduction Program website. The third is a syringe exchange network, so you can search by state to find resources near you. The fourth is a link to those specific fentanyl test strips that I talked about, which are available for purchase and seem to be pretty well validated. And then the fourth is, this is a site where I collected a lot of the information I used in this talk. Next slide. Some sources. Next slide. A couple of books that you may have already read these, but these I think touch on some of the topics we discussed, particularly trauma-informed care. Beautiful Boys, written from the perspective of a true story, written from the perspective of the father of a child suffering from substance use disorders. So nice resources there. Let's see in the chat. So if a patient, a 65-year-old male, chronically uses benzodiazepines and frequent injectable heroin use and reports previous bupe dose did not manage his pain, recently surgery and a surgeon restarted oxycodone. Patient is afraid of getting back on bupe as did not feel like it helps with the pain, not willing to go to a methadone treatment clinic. Would a higher buprenorphine dose be helpful? I think so. Are these prescribed benzodiazepines, or that's probably the first question I would ask? And it's helpful to know how much they're on, because that's a good risk factor to suss out. We don't titrate to pain control. For our purposes, we're really treating only substance use disorders, but it's certainly like he would meet criteria for that with heroin use, and so. Generally, as we said earlier, and Billie would like to have more to say, we generally are titrating the dose to management of cravings and withdrawal symptoms. And sometimes a patient will say, my pain is increasing my cravings. And so they can be very interconnected and related. A dose increase might be reasonable, but I think you'd have to look at the benzos more specifically. Billie, do you have other thoughts? You're muted.
I knew I was going to do that. I just didn't want. I had a little cough, and I didn't want everybody to hear it. But yes, the internet era of everyone talking while muted. Anyway, so I just want to say on this patient that the short answer would be maybe, but there's other things to consider with that patient and his pain. So one of the things is if his reasons for using heroin, if he was using on top of his buprenorphine, are pain, looking at splitting that buprenorphine to 4 times a day dosing, and still like 6 milligrams 4 times a day, or 8 milligrams 3 times a day, and at 24, and then prescribing the buprenorphine in such a way that you make sure they clearly understand the efficacy for pain lasts about 6 to 8 hours, while that its effectiveness and half-life is 36 hours. Its pain relieving or analgesic properties are really 6 to 8 hours. So that split dosing becomes important. And then, depending on what this patient's situation is or the clinician that decides it, in a situation like this recent surgery, my recommendation to that surgeon, had they already been on buprenorphine, would have been use oxycodone on top of the buprenorphine, not instead of the buprenorphine. Can you do that chronically? I have no experience with that, but for acute pain, yes. Looking at other analgesic medications to benefit pain adjunctively, other modalities like acupuncture and some behavior change therapies that we heard about earlier, in addition to the buprenorphine, and doing split dosing. And then just really looking at what dose of benzodiazepine and where the comfort is, maybe getting some pharmacist input on safety and what level. So I wouldn't say it's a no above 24, but that would be one that I'd be like, maybe not. There seems like a lot to that case.
But by the same token, as she just pointed out, bup and the benzo is likely a safer combination than heroin and the benzo. Yes. So there's that to consider too. So that's where it gets real uncomfortable, but we can relate. She says he's using diazepam 20 milligrams a day. He does state that bup does help with withdrawal. Might try to increase the interval, like you mentioned, and engage behavioral health. Yeah. And
I mean, I can honestly say diazepam at 20 probably wouldn't frighten me. But, definitely a collaborative approach is great.
I'm just here to remind people that if they have other questions about the previous comments, and it sounds like you're also willing to talk about specific examples that people may have in their own, in their own practices. I see Gary's got another.
So Gary, so that ends up being really and the impact team talks about this. There's a prescriber level. It really ends up that collaborative. In general, no. But if they're considered to have a surgery that would lead to moderate to severe pain in the post-operative pain in a very complex surgery, it may be more effective for their post-operative course to decrease their buprenorphine. It's very individualized. In general, we try to keep patients on the dose of buprenorphine they're on going into surgery. But that's another one of those cases where collaboration is key.
And also to call out that a patient on bup is going to need more opioid analgesia than your average post-op patient. And so you might feel a little scary, but you're going to have to go higher than you would ordinarily. And that's typical in order to get those receptors saturated.
I've also found it very successful in the post-op period to recommend that what the patient be prescribed for their pain is adjunctive buprenorphine. And if you get a surgeon or a clinical team that's willing to do that, it's better for the patient. So once again, collaboration is key in these cases.
I just have to say, from yesterday and today, it feels like that is one of the big themes that has come out of this conference. That it really does take a team to be most successful with these kinds of issues that we've been talking about. And I wonder, I know we're almost to the end, and Emily and Billie, as you have expressed that you've worked together over a long period, do you have any thoughts about that sort of collaborative approach, or how to implement it in the real world, which we heard earlier today, Dr. Sullivan talking about some of the difficulties, and you've been mentioning things around, there's all the things that everybody here knows, insurance and different, how do you bring people together, and what are any best practices you might share?
So one of the things I do with my patients on buprenorphine is I have a generic prescriber letter that I'll drop into a file note with my name, credentials, and signature on it. And I give it to the patient and I fax it to their provider. And make sure I already have the release of information with the patient already signed. And I tell the patient when they go to their pre-op to please bring it up and make sure that their team knows I want to hear from them if they have questions for me or need advice. So making sure the information is shared and being receptive has been the first part in helping with that collaboration. And I encourage my patients to advocate for themselves and help them understand why they want to talk about their buprenorphine and why they might want to request that their surgeon reach out.
And I think we've seen, personally, I myself been on a journey over the last decade. My own opinions and prescribing habits have really evolved. And I think, I'm much more comfortable with things that would have really creeped me out 5 or 10 years ago. And that just took time and experience, I would say. But the community as a whole it definitely feels more open to this than they did even a couple of years ago. So I think we have increasing acceptance of the medication and much better understanding of what to do in those settings, and better communication. So we hear from dentists and surgeons and other providers. The letter that we came up with says, this is my patient, this is their dose, this is what they're on, this is my recommendation, this is how to reach me, please call me. And people are pretty, and they want a dialogue. People don't want to deal with this. So they tend to want to reach out. So I think it's evolving, but improving.
Yeah. Well, and maybe even this conference is even, yet another step in that direction. As we've mentioned, people having the information and the opportunity to connect with each other and the collaboration is the key, and certainly in Central Oregon, but really it seems like it's even a wider, Pacific Northwest region kind of approach. So
I just want to put in a plug for that impact team. I call them and they've been great. Like I get some difficult cases. They've called me because they got one of my patients, and I've called them just for help, just because, I'm being asked about something that, the high levels of full agonist opiates. And I'm just like, let me make sure that I am correct. And so it whenever I have that feeling, I want to reach out and talk to others. Like, let me make sure. I don't want to be alone in this.
Yeah, and I would say that Billie, you're like at the leading edge of this field of medicine here locally, and so you can feel kind of lonely and isolated if you don't have support of providers around you, or if they don't understand what you're doing. And so, I agree. I found that team to be I call them on the weekends. They will drop everything. They're so interested in the case I have, and they want to help, and they provide really helpful feedback, and it can be very validating to understand that, yeah, I'm on the right track. This makes sense. We have a plan. So highly recommend. And so that's the general consult line that we've included in the PowerPoint. But when you call, ask specifically to be connected to the impact team or the addiction medicine consult service, and they will hook you up.
Well, and Dr. Harvey, that's a really great segue for me to remind everyone that all attendees will receive copies of all presentation materials later today via email, because I know there is a lot of, there's been such great specific information, and so people will have that quickly in their inbox. Sounds like the kind of thing to take out of your inbox and put into your contacts in your phone, so that you can just...
Yeah. They remind, speed dial.
Yeah, exactly. So, there is more time, and if there is more that you wanted to talk about, we would love it. I also have a sense that you may be towards the end of your presentation. And I see that Deborah is offering a little bit more. There's this question from Tom Quello. Does anybody have something? I don't understand
about the stimulant.
Yeah.
So we touched on that. I agree with Billie. I think, it would make sense that just as you're treating opiate use disorder with a partial opioid agonist, why wouldn't you treat a stimulant disorder with a stimulant? And so I think the idea holds merit. My understanding is that there hasn't been a ton of research yet, and that what research has been done hasn't been a real slam dunk. So they're looking at outcomes like the patient's report of return to use of stimulants, but also their urine results, and those don't often jive or add up. It's what we will see often are patients who may have co-occurring ADHD or ADD, and so we're asked, and they have a stimulant use disorder, and so everyone is very uncomfortable. So I would say that kind of older school mentality of addiction medicine and substance use treatment would be that abstinence only. You cannot be on a stimulant. You'll never get a stimulant again. And so then another psych provider may be saying, well, I think this might be appropriate for this patient. People are complicated. They have more than one diagnosis. So we handle those cases, on a case by case basis, and really review all the information. But we have several patients that are on a stimulant, and we are checking in with periodically and getting urines, and there are people out there who I think do better on a stimulant and are able to function normally, which is what we want to see, and they don't return to use. So that's completely anecdotal. There isn't a ton of data there, but it is absolutely getting attention, and I get asked about it regularly.
And now that the word occurred to me, it was modafinil that there's actually a study. I don't know how many people that happens to, but there's a word I want. It doesn't come for 30 minutes. Anyway, modafinil, there's 2 larger studies. One was kind of really positive as far as negative UAs for methamphetamine, and the other one was a little more indifferent, like plus minus. So the case that I talked about, I tried to get modafinil approved, and then I ran into the barrier of insurance. And I mean, it's not that expensive as far as with a good RX coupon, but I couldn't get the patient to trade his methamphetamine supply for modafinil, even though when I tried to weigh the cost for him. So I guess he wasn't ready. I was going to try it. I did not get to. And I could not get insurance to cover it. I tried to be very transparent about why I was considering it. That might have been why I didn't get it approved.
Stimulants are really hard.
Yeah.
And options.
Dangerous and damaging too. I'm not sure which of the plethora of substances out there I consider most harmful, but it changes by who I see.
Well, I would like to say thank you, Dr. Harvey. Thank you, Emily, Billie, for all of your work, for your time this afternoon. And I'm guessing people may chime in and thank you a little bit in addition.